Hello, I'm Christine Peshkin. I'm an associate editor of the Journal of Rheumatology, and it's my pleasure to welcome you to this interview featuring the authors of an important article from the upcoming September 2025 edition of the Journal of Rheumatology. Today, I'll be speaking with Dr. Keren Cohen-Hagai, Shaye Kivity, and Oshrat Tayer-Shifman. They are representing all of the authors of our featured article that's titled Prevalence, Risk Factors, and Outcomes of Chronic Kidney Disease in Patients with Systemic Lupus Erythematosus with and without lupus nephritis. Thanks very much for taking the time to speak with me, all of you.
Thank you.
Thank you for this invitation.
So I'll start with, if you can please give us an overview of your medical center and the rationale for this study.
Sure. So Mayor Medical Center is a 800-bed academic hospital. It's affiliated to Tel Aviv University, and it's located in the central of Israel, just above Tel Aviv. It serves largely urban Jewish and Arab population. It has some 35 inpatient departments and 100 clinics. And the Mayor Medical Center belongs to a chain, actually, of 14 hospitals, which belong to the HMO, the largest HMO in Israel. It's called the Clalit HMO. And this study is the fruit of a strong collaboration between Professor Cohen and Dr. Shifman. Tayer-Shifman is the head of the Lupus clinic in our institution, and Professor Cohen is the head of the nephrology department, and they have a conjoint rheumatology nephrology clinic which treats immune-mediated kidney diseases, mainly lupus nephritis.
Great.
So
yes.
So, like Professor Kivity said, our study was mainly the rationale for the study was mainly started from the clinic itself. We sat and saw lupus patients even without lupus nephritis, and then we saw that we have a lot of patients with CKD, with chronic kidney disease. We said it's something we overlooked. So this was one reason for doing this study.
Okay. And you partially answered this, but what was the aim of the study?
So the aim was to assess the prevalence of CKD in lupus patients, so patients with lupus with and without lupus nephritis, and to explore the major risk factors for developing CKD in lupus patients, and to also explore the outcomes, the long-term outcomes, infections, hospitalizations, sorry, cardiovascular disease, and mortality, of course.
And can you please go over the methodology of the study? And I also wondered why you chose 2014 as the starting year for the review. I did see that patients go back before that, but that's...
Yes, you're right. Actually, it was a retrospective study that was based on our hospital database. And we review each patient medical history individually, and we calculated EGFR at important key point, such as the baseline before SLE diagnosis, at SLE diagnosis, and during follow-up. And we chose 2014 as the starting year, since from this year and onward, the database of the Clalit became fully electronic, so we could ensure that the data is accurate and reliable. We had actually in the Clalit we have all the blood tests and urine analysis and such from 2000, but all the medical records were available and reliable from this year and onward, so we choose this year as the starting year, and we did have a follow-up of 20 years. So I think it's a long-term follow-up, and it's a good follow-up after patients, so we can know and discover the outcomes of these patients.
And can you go over the methodology?
Yes, so as I mentioned, we add all the patient medical record that was electronic, and we could look for is chronic diseases that it developed during the follow-up, and of course all mortality, hospitalization, blood test, urine test, everything was available for us. And we collected them all. We first reassured that patients were with SLE, and then we checked if patient had lupus nephritis. We defined it as per kidney biopsy. If patient have lupus nephritis per kidney biopsy, so we defined it as lupus nephritis. And 1/3 of the patient did have lupus nephritis per kidney biopsy in our cohort. And then we looked during the 20 years, almost 20 years of follow-up, who developed albuminuria, who developed a decrease in estimated GFR. And we defined the CKD in our study as the KDIGO defined, which means or decrease the estimated GFR below 60 milliliter per minute, and or albuminuria more than 30 milligram in two separate tests. So we could really recognize all patients with CKD.
And your outcomes, I think, were CKD, but you also looked at mortality as an outcome, I believe, right?
Yeah, and we have a good registry of mortality, so we can be sure that patient, even if patient were dead at hospital or at home, we knew it. So it's a very good database that from all hospital and from the that is very reliable and accurate in this term.
And you touched on this, or I think it was Dr. Tayer-Shifman who touched on it a bit, but what prompted you, why was it important to study kidney patients, or kidney outcomes rather, in patients without lupus nephritis instead of the usual with lupus nephritis?
Yeah, I think it's very well recognized for everyone, for rheumatologists, for GP, for everyone, that patient with lupus nephritis is a kidney disease, and it goes without saying, and it makes sense. But as a nephrologist, it's very important for me to emphasize and to discover also patient with SLE without without lupus nephritis. They are also at risk population for CKD. And 10% of the general population have CKD, and patients with SLE, even if they didn't have lupus nephritis, they are at increased risk for CKD. And now in this area of all the new agents and therapies for CKD, it's so important to do this screening and to discover them, because we know that all the new therapies for CKD treat not only the CKD, not only the kidney disease, not only the kidney disease. They also reduce mortality, they reduce cardiovascular morbidity and mortality, and it's such important treatment for this patient. I mean, when we take patient with chronic kidney disease with albuminuria at its early phase, before the GFR decline, and we treat him, we reduce his risk for sudden cardiac death, we reduce his risk for acute coronary syndrome, for many other things not only to reach end-stage kidney disease. Treatment for CKD are important treatments not only for the kidney themselves, but also for another target organ damage, and actually it's like a game changer. It's a life-saving drugs, not less than immunosuppression therapy.
Did the high prevalence of CKD in the non-nephritis patients surprise you?
I think it surprised us. We were expecting a high prevalence of CKD actually, but we found that almost half of patients with CKD never had lupus nephritis before. So who are those patients? And probably there are interplay, like Professor Cohen said, between other mechanisms of lupus, inflammation, accelerated atherosclerosis, hypertension, diabetes, side effects from steroid treatment that probably add to this development of CKD. So it really did surprise us. And we think that now that we see that half of the patients with CKD are not with lupus nephritis, I think that the striking thing is that we are used to follow patients with protein, all lupus patients, and especially patients with lupus nephritis. And now, after we saw those patients and we saw the numbers of patients with CKD, we feel that we need to follow these patients with albuminuria also. Like Professor Cohen said, it's an early sign of CKD. It's the time frame that we can intervene and treat with our kidney protective agents. And we know from our cohort that most of the patients that we defined with CKD, they had albuminuria and not EGFR decline. And we know that albuminuria from other studies, not in lupus, but in patients with CKD, that albuminuria itself without the EGFR decline is also associated with severe outcomes like cardiovascular morbidity and mortality and other severe outcomes. So that, I think, is one of the most important things about this study.
And it's important to note that CKD, it's not just diagnosis. It's a disease that we can treat. We have the albuminuria. In Israel, for example, the treatment are cost effective. I mean, it's only cost us like $1 or $2 to check if patient have albuminuria, and the treatment are life-saving and they are game changer, and we can help this patient. And it's important to do the screening and to recognize them and to treat them, because there is a lot of benefits from this treatment.
So I'm hearing that this work has changed practice, or it's going to change practice in your clinic, and you're suggesting sort of more protocolized follow-up of all patients with albuminuria specifically. Is that right?
Yeah, I think we should be more proactive. Like diabetes patients, we know, everybody knows that you should monitor the albuminuria. I think we should be more proactive with our lupus patients. We know that all the risk factors, the management of risk factors is very important in lupus management. With managing better the cardiovascular risk and the mortality risk, we know that the patients are dying from cardiovascular disease at the end. We need to treat it better. There is still a mortality gap in lupus patients, although we treat them much better nowadays. So in the last 20 years, we really didn't improve mortality rates of lupus patients. So I think that by managing risk factors, hypertension, diabetes, and also CKD, maybe we can have better prognosis. So yeah, we do think, I do think that we should monitor the albumin. And if I see, and I think it's also the collaboration with the nephrologist, because when I see hyper or albuminuria, which is more than 30 milligrams a day, and I don't need to do a biopsy. I don't think it's lupus nephritis. I don't think to treat the person with immunosuppressants. But that's the time to also involve our nephrologist to give them the best treatment for CKD that they can. So for our clinic, we are changing the practice.
I think the take-home message that we would want the readers to take is that proactively screen the non-lupus nephritis patients for kidney involvement, because we probably have some tools that can help them today that we didn't have years ago.
Exactly. Kidney involvement is not just lupus nephritis, it's more than that.
Yeah.
And how often would you suggest screening patients? Because you have very long follow-up of 20 years in your cohort, so.
I think that like we do in diabetic and in other high-risk population like hypertensive patient and patient with atherosclerotic, like 1 to 6 months or to 12 months, it's to make sure if the patient has albuminuria, we should treat him, not just screen him and follow up after him. But if you don't have, I think that do the screening, check all not only the albuminuria but also the kidney function at least once in a year. It's important.
And I'm hearing also a suggestion for sort of closer collaboration or referral to nephrology for those with persistent albuminuria.
Yeah, it's a long-lasting argument between rheumatologists and nephrologists who treat the lupus nephritis patients. I think we should both treat them. I think the collaboration is very important for the clinic and also for research like that. I think this study wouldn't be done without the collaboration between the rheumatologist and nephrologist. And without our conjoined lupus clinic, I think that the patients, they really gain from seeing us both together. And I think that we learn from one another also a lot. I know I'm much a better rheumatologist now because I know more of nephrology. And I think also Professor Cohen, I talk for you, but I think you're a much better nephrologist now because we see the point of view of each other and we argue sometimes even, but for the sake of the patients. So I think everybody gain from that, the patients and also we do.
Great.
Absolutely. It's complementary.
Can you tell me a little bit about the major findings in terms of how the patients with and without lupus nephritis differed or were similar? What you found there between the two groups?
So the two groups, they developed CKD. The difference that we saw that the patients with lupus nephritis developed it earlier. So that's very. I think it's not surprising because we know that lupus nephritis as a diagnosis, it's already every patient with lupus nephritis actually has CKD because we know that nephron loss and damage of the kidney starts really early in lupus nephritis. So it's not surprisingly that they do have CKD by the KD definition earlier than the other patients, but both groups with lupus nephritis and without, they both suffered the same complications, the same comorbidities, the same worse outcomes as for mortality, for instance. We saw that almost around 19% of patients with CKD died in our follow-up, as opposed to something like 1.5% of patients without CKD. So the mortality rate is striking. Even after we did some adjustments and some for covariables, and we also we got a trend for more mortality, higher rate of mortality in the CKD patients. So we think that the reason for the CKD is not so important as the presence of CKD.
Can you follow up on that a little bit? The last sentence about this.
So we saw that both patients with nephritis and without, when they had CKD, they had worse outcomes, more hospitalizations, more cardiovascular events, more mortality, and it wasn't related to lupus nephritis or not lupus nephritis driven CKD at our cohort. Of course, we couldn't do.
What Dr. Shifman is actually saying, it's different pathogenesis of the kidney damage, but same final common pathway: increased mortality, increased cardiovascular risk, and higher risk of end-stage kidney disease. And it's an adverse event that we can't prevent. I mean, we can discover them early and during the reversible phase, and we can treat them. And that was the aim of the study, and I think it's the main clinical implication of our study.
Great. And can you comment on the strengths and weaknesses of the study?
Yes. So I think the nature of the study was retrospective and single-centered, which is and based on the EMR data. Another limitation is the perhaps underestimation of kidney disease because albuminuria is not routinely checked in patients, and obviously not all the patients had kidney biopsies. But on the other hand, there were the strengths of the study, that it was a really long study, it was almost 20 years, and it did include what is less done in other studies. It included also kidney impairment, not just based on GFR, but also on albuminuria. And it focused on Middle Eastern, it's a genetic different than what is studied usually, Arabs and Jews, which is distinct probably ethnicity, and also focusing on the non-lupus nephritis patients is also special for this study, is a strength of the study.
And your numbers, I mean, at 175 patients, and then the group with CKD, I mean, it's striking that you found the outcomes, you know, with relatively small numbers, that you found these striking differences or findings. I'm wondering if you think if this was done in other centers as well, in addition to the ethnic background, which is interesting, whether things would potentially change. There are other groups that are very high risk for renal outcomes, you know, the patients of Black heritage, or for us, our indigenous population might be even more striking, but also whether we'd be able to find out anything, any sense of whether any particular drugs or treatment or other things might come out with larger numbers. If you got any sense of that from the data?
I think the next step is to try to look for CKD patients in other cohorts, larger cohorts, prospective cohorts. We know that there are a number of lupus cohorts, prospective ones. The problem is, I think one of the problems are that the most of the cohorts, they do not systematically collect urine albumin. And that's one of the problems to do that. I think our cohort had relatively high numbers of urinary albumin. We didn't have a lot of missed samples. I think sometimes it's it's a miss. Maybe I think family doctors are very used to send albumin in Israel. So sometimes even when we ask for protein, they send albumin. So we have
Which is good.
yeah, we have a lot of albumin samples. I don't know if in the prospective cohorts, in formal prospective cohorts, they will have enough data on the albumin. But I think we just have to start in checking this.
Yes.
And
I also wonder whether you had albuminuria on almost everyone, and if that's because of your close collaboration with nephrology that you had. I just wondering because I know we often have both in those.
So this is part of the story, but we had other group of patients, we didn't have albumin for them, and we used protein as a proxy for albumin measurements. Mostly lupus nephritis patients that they have still have residual proteinuria. But I think, probably the nephrology, the very strong nephrology in our hospital, we send more albuminuria to patients even before the study was done. I think this is part of the story, yeah.
That's great. Is there anything else that you would like to add that we didn't talk about?
I think another thing is really the interplay between the CKD. CKD is part of maybe late complications of lupus, like we see the accelerated atherosclerosis, hypertension, diabetes maybe. So we see those patients with maybe their lupus is not active anymore, but they have late complications of lupus. And I think we have to add CKD to that basket of late complications and monitor for that. So I think this is one of the take-home messages, the important take-home messages. Because now I think, like Professor Cohen said, now we have treatment for that. Before we didn't have such treatment for CKD, so maybe it was a little bit neglected because, okay, he has CKD, what can we do? But now because we have treatment for that and a very important treatment with life-changing outcomes, I think we should add the CKD to the basket of late complications, late onset complications of lupus.
Yes, I agree. That's certainly my take home, that I will start adding that as well. So food for thought for everybody.
Not something job for us.
Exactly. In fact, I usually complain when I ask for proteinuria and get albuminuria instead. Now I won't complain anymore. So, great. Thank you again for discussing the findings of this paper. So to our viewers and listeners, please have a look and read the article that's titled again, Prevalence, Risk Factors and Outcomes of Chronic Kidney Disease in Patients with Systemic Lupus Erythematosus with and without lupus nephritis. It's on the journal's website at jroom.org, and it'll be featured in the September print edition of the journal. And thanks again for joining us, and we look forward to having you with us next month for the October 25 edition of the Journal of Rheumatology. And you can share your comments on X at jroom, or you can email us at manuscripts@jroom.com. Thank you again.
Thank you so much for the opportunity.
Yes.